Yeah.
All right. Anyhow, let's get started on this. This is going to be a very basic topography, and we'll go through some of the principles and so forth that are involved with topography. Let's see if I can get this to move ahead. Yeah. So to start off, I thought we'd just have a couple pre-lecture questions, and you can look out for these answers in the lecture. Question number one is, corneal topography gives us elevation values, true or false? We don't have a poll for this, so you just have to keep your answers to yourself. And question number two is, corneal topography gives us A, accurate curvature readings of the posterior surface of the cornea, B, good readings of the central point of the cornea, C, color-coded maps of the tear film, and D, is not useful in the diagnosis of keratoconus. And the third one, this is for those people that are into pattern recognition. This patient has A, pellucid marginal degeneration, B, Fuchs dystrophy, C, keratoconus, or D, epithelial basement membrane dystrophy. So with that introduction, we'll go on to talk about some of the principles of corneal topography and the information that we're able to derive from it. And then we'll go on to discuss where it's useful and the clinical applications that we use corneal topography on now on a daily basis. It's hard to imagine life without corneal topography. But the concepts have actually been around for quite a while. The Placido disc, which is still can be a useful instrument, was actually invented in the 19th century, and also the Javal keratometer, which we still have a version of that in the clinic, is still a very accurate way of measuring the curvature of the cornea. And then in 1930s, the classic B&L keratometer, which you'll see over in the picture on your right, and has essentially been unchanged for almost 100 years or 88 years.
And can have a little bit of callus. It is a much.
Now, when I started, we had the keratometers, obviously, and my first device that could give us an image was called a corneoscope, and it actually gave us just a recorded keratoscopy. Sorry, can you mute your mute your and this is an image with the device was about this big, and the patient would sit at one end of it. It had a Polaroid camera on the other end, and it would take a picture of the corneal rings on the cornea. And I still go back to this. It's many times because I think it's important to look at the rings. You get a lot of information that sometimes, if you don't have the rings, it's difficult to interpret just the color-coded maps that we get printed out. And the principles are quite simple. If we know the size of the ring and we know the distance from the cornea to the camera, then we can use the ring size to estimate the curvature of the cornea. You have to emphasize that we're not really measuring the curvature of the cornea. We're actually measuring the curvature of the anterior surface of the tear film. And it's excellent. It's really become the basis of modern cornea and cataract surgery. But it does have the limitation that it only looks at the anterior surface of the cornea. And that's important to note when we move on to a more advanced technology, or I guess it may not be more advanced, but newer technology in terms of the pentacam, which gives us measurements of both the anterior and the posterior surface of the cornea. And this is what the keratous rings look like. This is taken from an OPD2 scan, and the computer will photograph those rings and digitize them, and then give us a computerized map. And just to throw in a little bit of a personal vignette, when I was applying for fellowship, I went down to LSU, and one of the people that interviewed me, his name is Steve Kleiss, and many of you may have heard his name before. He's actually, I would call him the father, and maybe now the grandfather of corneal topography. And I sat down across from his desk, and he asked me about me, and then I asked him, well, what do you do? And he says, well, I'm developing a system of mapping the cornea. And I said, oh, that's interesting. And he pulled out all these papers, and they looked like a Spider-Man map or Spider-Man net that had been just thrown onto the table. And I said, well, that's interesting. What are those used for? And he said, well, they're used for diagnosing keratoconus. The overly smart third-year resident thinking that I knew everything, I'm thinking to myself, gee, there's a lot of better ways to diagnose keratoconus than that. And I was fortunate to be at LSU at the time when he was developing the color coding, and we used to use it wasn't even a printer, it used color marking pens that were computer controlled, and it would color these maps and give us these beautiful printouts that we're so used to seeing now. So, little did I know that I was I was in the presence of the person that developed an instrumentation that was instrumental in helping us understand the cornea. So once the computer algorithms came along, the first one was what we call a sagittal map. And I'll show you some pictures of that. And what this does is it represents the curvatures of the cornea in different colors. What are the advantages of topography? It's better for measuring the anterior topography, which measures elevation data. And this is controversial as well. I don't really know what the right answer is, but many people will say that topography or Placido technology is better for measuring the anterior curvature of the cornea. And the explanation that I've been given is that because when you're measuring elevations, you're looking at microns and submicron values. Whereas when you're looking at curvatures and you're doing it with Placido technology, you're actually measuring quite a broad span across those rings. And so you can get a more accurate difference map and a more accurate representation of what the surface curvature is. Whereas with tomography, you have to be accurate to submicron levels to get that same kind of accuracy. So when I look at a tomography map, like a pentacam, and it shows usually on the left-hand side, it'll show you the topography. I really don't call that topography. I call it simulated topography. Is that these are these are maps that have been reconstructed from elevation data. They're not curvature maps the way that we think of when we think of Placido technology. And here are some of the negatives of corneal topography is that with the earlier topographers, a smaller part of the cornea was measured, mainly the center part, which most of the time is what we're most concerned with. But you can see that at least in this early topographic image, there's a great deal of the corneal surface that hasn't been measured. It's based on spherical assumptions, and That's not necessarily a bad thing, but it gives us certain artifacts that we've become used to, such as the bow tie appearance of the cornea. The cornea really isn't a bow tie. You won't find any cornea in nature that looks like a bow tie. It's just an artifact of having been standardized against a spherical surface. And really, the more correct representation is a cylinder, a modified cylinder in two different directions, of course. But you don't really have a bow tie or an airplane propeller kind of view. The other criticism is that it tends to overestimate the size and location of cones in conditions such as keratoconus. It assumes an axial measurement, and the other down point is that the center part is often ignored. The very, very center of the cornea, depending upon the size of the central ring, that's a true criticism. However, as the topographers have improved, we get more rings on the cornea, so we get peripheral imaging, plus the size of the central ring is smaller and smaller. So the area of the cornea that's actually ignored is probably not significant. And here's an axial map, or another name is a sagittal map. And just ingrain in your memory that when you're looking at an axial map or a sagittal map, what we're really looking at is a map of the curvature of the cornea. And in this one, I like to find representations that give us green being good. And the only way to do that is to set your scales. So we need to talk a little bit about scales and also the interval of the scales. But in general, we think of an average cornea being somewhere around 42, 43 diopters. And on this representation here, 42 or 42 and a half is in the green zone, and it only starts to go up into abnormal zones when it's above 45, where the colors start to change. So you need to look at the color scale, and you need to look whether it's what kind of scale it is. Here we'll talk a little bit more about it, but this is an absolute scale, and it's in the Smolik-Kleist representation. Smolik is a researcher that worked with Steve Kleist, and they came up with this representation, and the intervals are 1.5 diopters. So you can see it goes 30, 31.5, 33, et cetera, all the way up to 67. So we start with the cool colors, the blues, go into the green for normal. The other way you can look at it is it's like a topography map. You know, the surface of the land is green because there's grass there. And if you go below the surface, it turns blue, and the hotter colors are the higher numbers. So this is a fairly normal looking axial map. The other interesting representation is what we call tangential. It's also been called instantaneous or meridional. And I always wondered what instantaneous had to do with anything, but then my friend, former fellow Dr. Kaiserman, explained to me, and it makes perfect sense, that instantaneous refers to the first derivative, going back to your first year calculus in university. So it's the first derivative. And what is it the first derivative of? It's of an axial map. So we're taking the derivative of curvature. In other words, we're not looking at curvature when you look at tangential maps. We're looking at the change in curvature. And that's important to remember, because when we look at some of these maps afterwards, you'll see that there may be a red zone, and it may not necessarily represent where the cornea is steep, but rather it may represent where the cornea is changing is changing more rapidly. For instance, we'll see later in a myopic PRK or a myopic LASIK, there's a red zone, and we can use that change to help us with looking at post PRK or post LASIK patients. It tends to be more sensitive, so you get a lot more noise. So if someone has a very subtle change in their cornea, it's going to be picked up more easily on the topography, on the tangential instantaneous meridional map compared with the axial, but it may not be clinically meaningful. The thing it does do is it helps you hone in. You see that there's some irregularity there, then you go back to the axial map, or you go back to the placido rings to help you interpret, and even go back to the slit lamp. And believe it or not, sometimes you have to go back and actually look at the patient. So it looks at the changes in curvature, highlighting small changes. And here's that same patient that I showed you before, and it's an instantaneous map. Now here, on the OPD scan, we can set it for any number of readings. It's giving us the simulated keratometry, and I'm not sure which is more reliable, but if I'm going to use the Ks from topography, I tend to look at the curvature maps rather than at the instantaneous maps. Now, maybe someone out there in the audience can elucidate us better to that. But when I'm looking, for the keratometry readings, I'll go to the axial rather than the instantaneous. And once again, this is an absolute scale, so green, this color green always represents 42 diopters, no matter what cornea you're looking at. Now let's talk a little bit about scale. There's a normalized scale, and what that means is that it'll take the lowest measurement that you've got and it'll take the highest one, and then it'll spread the whatever 16 colors in between into equal steps. The problem with that is that every cornea is going to look different. So if you've got a normalized scale, a keratoconus will look different with a normalized scale, and a more extreme keratoconus will also look different. So the color, in other words, the colors aren't consistent. A 42 isn't always green, and I think that leads to difficulties with comparison, particularly if you're trying to compare maps that have been performed, say, on an ISIS, and then trying to compare that to a Zeiss topographer, or trying to compare that to an OPD scan. As it is, it's extremely difficult, I find, to compare maps. When someone comes in, they come in with a whole, binder full of maps from 4 different locations and from 5 different machines to try and compare. Is this patient progressing with their keratoconus? Have they stabilized? How bad is their cornea really? So the best way is to instead rely on an absolute scale. The same colors always refer to the same diopter. And there's a big difference depending upon the size of the steps. And I'll show you some examples that try and hammer that home, that really matters the size of your steps. But at least this gives us some consistency, and we at least have a chance of comparing maps from different machines. There's 2 other scales which I just mentioned here as an aside. I don't think I've ever used them, but I guess having been humbled by my association with a giant like Steve Kleiss, I rely on whatever he says, and I've heard him say is that his scale of using the SK scale 1.5 diopters absolute is the most accurate representation of what the cornea is doing from a refraction point of view. And if he says it, I have a tendency to believe it. But let's just look at an example here. This is a normalized scale, so the colors are going to change. And this is what this patient's cornea looks like if we put the steps down to quarter diopter steps. And you can see 41, 41.25, 41.50, et cetera, et cetera. All right. Now, let's look at it the same with the same normalized scale, but we're going to change the steps. Now it's double that. And the one on the left looks kind of, oh, what's going on here? You know, he's got all these irregular islands, but now it's starting to smooth out a little bit by adding the half diopter. And then this is the same cornea, which if you saw this, you would say green is good. And this is a fairly normal cornea. And this is an absolute scale, so we know that the green is going to be in the normal zone. And by increasing the steps, as you can see here, 3150, 33, 3450, by doing that, we've removed a lot of the noise and gives us a more normal appearance to this cornea. And that's important. Sometimes you'll see people present at meetings, and they'll say, "Oh, look at this patient has obvious inferior steepening." But you look at the scale, and it's a normalized scale, and it's quarter diopter steps. Well, that's what I like to say is that you can turn almost any cornea into a keratoconic cornea if you adjust the steps and the color scales to your advantage. So always be mindful of that when you see someone's topography up there. See if they've really paid attention to the scales. Or sometimes they'll show you the same patient, and in one view it'll have one scale, in the second view it'll have a different scale, the third view it'll have a third scale. So this is what I suggest is listen to what Dr. Kleiss has suggested, which is the Smollett Kleiss scale. Just to review, it's absolute 1.5 diopter steps. It's good for picking up most corneal pathology without overcalling the pathology, with the understanding that you might miss some subtle irregularities, but for that reason, we don't just look at the axial, we look at the tangential, and we look at that in concert with our placido disc rings to see if it all lines up and if it's all meaningful. Here's an example as well that in this patient, this is the instantaneous map, and if you look, the scale, it's adjustable, so it's a normalized, adjustable is the same as normalized, and it's 0.25 diopter steps. Oh, sorry, and here's the same representation in axial, and if you look at this at first glance, you're saying, this guy, maybe he's a form frus keratoconus, or maybe he's a keratoconus. Look at the inferior steepening. But as we change the scale, this is once again adjustable, but we change it to 1.5 diopter, all of a sudden the inferior steepening isn't quite as obvious. And if you compare the superior and corresponding inferior point on the cornea, you're only looking at about 3/4 of a diopter of change. So that goes back to my saying that you can turn any cornea into a keratoconic one if you adjust the scales fine enough. And this is that same cornea adjusted to an absolute scale with the Smolik Kleist values of the steps being 1.5 diopters. And, we've got we should be suspicious. I'm not saying you should ignore these things, but don't panic. Like when you see this here and you say, wow, this patient's got keratoconus, we better stay 10 miles away from him with a keratome or with an excimer laser because we're going to cause ectasia. That may not be true, and we may need more information before saying that patient is not a candidate for refractive surgery. So here's why I like the rings, is that sometimes you can end up with artifacts. And these are some of the artifacts, and I'll show you some examples of lid artifacts, tear film artifacts, nose shadow, and the pupil margin edge. This is the ring tracing from an OPD2 scan. The OPD3 has more rings on it, but the two demonstrates how the computer actually gathers the data by looking at the inside and the outside of each of these keratoscopic rings and calculates them into a color-coded curvature map. This is from an OPD3. The rings are much more narrow, and I believe there's 30 rings, and it goes out almost to the limbus and ignores very, very little of the central cornea. And this is to show us that how the instantaneous or tangential map gives us almost too much information. And if you just saw this, if that's all you had was this upper left-hand image, you might believe that, well, this is a highly irregular cornea, right? There's all these little islands. The truth is that there's very little in a smooth cornea that's going to give you islands of steepness, so to speak. It's not really steepness, it's change in curvature. And a lot of that disappears when we look at it on the axial representation. So by changing the algorithm, we smooth out, get rid of some of the noise. And here's where the placido rings really come into play, is that these help us interpret what's actually being interpreted as these hot spots on the tangential map. And from the patient's cornea drying out, either they've got a dry eye or they've had lots of drops of anesthetic because the topography was done after the vision and pressure was measured, and they're not blinking enough, so you get these dry spots, and that can give you an erroneous interpretation. But having seen this, then you know to look, does this patient have SPK, or did they just they were told to don't blink, don't blink, don't blink, don't blink, and 30 seconds later the picture was taken and ended up with some dry spots on the cornea. Here's an example of irregular astigmatism. Once again, the tangential map gives you this awful looking appearance, but just remember this, we'll see this picture later on in the lecture as well, but there's this blue circle around the outside. So those of you in the know may already have an idea what's happened with this patient, but I won't give it away just yet. And on the axial map, it's a little bit more regular looking. And by looking at the, you can see that this is a very irregular cornea, possibly due to dryness or to, post-surgical condition. You can, on this map, there's a crescent where you get absolutely no information from. and that turns out as a dark spot on our axial and our instantaneous maps. And this is actually from the shadow of the nose. So what can we do if we need information, particularly in that region? You can just tilt the patient's head slightly. Just turn it when you're looking at the right eye. Have the patient turn slightly to the left, and then have them fixate at the target in the topographer, and that will get rid of the nasal shadow. And likewise, we've got this blue zone up here, but if you look at the Placido image, we actually have a lack of data due to the eyelid shadow. And now you want to be careful not to, if you're going to elevate the eyelid, don't put any pressure on the globe, because that's going to change your curvature. Or just ask the patient to open their eyes as wide as possible, and then you click the button to capture a better image. Now, if we go back to this one here with the irregular cornea, if you think it's due to dryness, don't put artificial tears in, but rather use just balanced salt. So keep a bottle of balanced salt solution beside the topographer. Put 1 drop of BSS in, have them blink, 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 blink several times, and then try and take the picture while the cornea is uniformly moistened. Because remember, once again, we're not really getting pictures of the topography of the cornea. We're getting pictures of the anterior surface of the tear film, which in a healthy eye is probably one and the same. But you don't want to put artificial tears in there, because they have a higher viscosity. They may actually induce some irregularities and maybe not give you an accurate reading. And then the third thing to look for is illogical patterns. Everything has to make sense. So if you've got these multiple islands of red, you've got to wonder, is this really a true representation, or is there something else going on there? Or if you, let's say, for instance, you get steepness where it's not your area, I think it's possible to have superior keratoconus. I think it's probably as rare as hen's teeth, but nonetheless, it is possible. But if you do see a steepening of the superior cornea, you should wonder. At least don't take it for granted that you're dealing with superior keratoconus. Now, in this picture, it's an instantaneous map. So once again, it's going to pick up very subtle irregularities. And you've got these two rounds, one above the pupil and one below the pupil. And if we look at the Placido rings, particularly with the overlay of how the computer has gathered the information, the computer has skipped a little bit here, probably confused by the image of the pupil, and has given us these two funny looking red spots on the topography. So here once again, we're just going to go back to a normal map. We get a little bit more noise, a little bit more variation in the color with the instantaneous or the tangential map. And the axial map in the lower left-hand corner. We've got nice Placido rings, and on many of the topographers, we get a lot of information. We've got the cylinder calculated for us. It's got a Q factor put in there. The cornea for us with some artificial intelligence. This one being just telling us that there's a high probability that this patient simply has astigmatism, and in fact it's with the real astigmatism. So now with that basis, if anyone has any questions, we can break for a short time here, or if you want to save your questions to the end, whatever. Is there anything on there, Tanya, that anyone asking questions?
If anyone would like to point any questions, you're welcome to use the chat function at the bottom, and we have some moderators who are happy to take the questions. But so far, Prof, nothing's come through.
Okay, great. So I've dumbfounded everybody so far. So, well, now with that background, let's go on and talk about the applications, some of the applications of topography. I've listed 4 here: keratoconus and thinning disorders, refractive surgery, cataract surgery, and of course, corneal surgery as well. We talked earlier about how the axial representation may not give us the true size and position of the cone. However, it does hone us into the diagnosis, keratoconus. I think sometimes the axial may overcall the diagnosis of pellucid marginal degeneration, and we'll see an example of that later on. But just remember, everybody thinks about the kissing bird sign or the crab claw sign, and if you see a picture of a crab claw or the kissing bird sign, don't automatically jump to the diagnosis of pellucid marginal degeneration. And of course, what we're all looking for is the needle in the haystack, which is the patient who has a normal anterior curvature yet has an abnormal ectasia or elevation, bulging of the posterior surface of the cornea. And topography doesn't give us any information about the posterior cornea. So there will be the occasion, and they're very hard to find, at least in my experience, of someone who has a normal anterior surface and has an ectatic posterior surface. So here's an example for all you people that are in recognition. That's why we're in ophthalmology, or one of the reasons we're in ophthalmology. But this is a typical representation of topography from a patient with keratoconus. The instantaneous is in the upper left, and you can see here that there's rapid change in the curvature of the cornea centrally, and that translates on the axial map into a highly elevated curvature of the cornea, mostly inferiorly. Now, if you compare the two, the tangential will correspond more readily to the tomographic maps or the elevation maps for the central position of the cone. Whereas the axial one tends to exaggerate it a little bit and makes it seem larger than it actually is. And if we look here, the IA on the OPD scan tells us that this patient is most likely a keratoconic. We didn't need the IA to tell us that, but nonetheless, it's nice to have a confirmation of it. And if you look at the placido rings, where the rings are closest together represents where the cornea is steepest, and you can usually divine the steep axis of the cornea by finding the spot where the opposite sides of the ring are closest together, and then drawing a line through it. So I would have estimated that the steepest axis on this cornea is somewhere around maybe 105 degrees, something in that range. And you can see the line here is drawn closer to 90 degrees, and yet the steep and flat axis, according to this, is it's at 150 for the steep axis, which would be probably somewhere around here. So sometimes the numbers don't. Sorry, go ahead.
Sorry. I just had a
Tanya?
question come through. Just to expand on the superior steepening on this topography, please.
Expand on what, sorry?
Superior steepening on this topography.
The superior steepening?
Well, sorry, that's just what verbatim the question. I think they just wanted more explanation of the superior aspect of this topography, I think is what they're trying to ask.
Okay. It's actually, what this is showing is that it's showing, if you look at the axial, as typical in many keratoconic patients, is that the superior part of the cornea is actually fairly normal. If you were to take a sheet of paper and put it across the bottom part of the topography going through the pupil and just looked at the upper half of the cornea compared to the lower half, the upper half looks pretty normal. In the upper one, what we're seeing is that's a little harder to interpret. You're quite correct. I think it's showing us a negative change in curvature. It's not really that the cornea is 31 diopters or 30 diopters superiorly. Look at the axial or the actual curvature map for those numbers, and you'll see that the superior cornea is actually about 40 or 42, something in that range. Did I answer the question, or if that isn't clear, let me know. But
I think that's fine.
Look at the instantaneous map to find where the cone is steepest. Look at the axial to look at where the cornea is most normal. That's, I guess, one way of looking at it. And I think it explains, once heard Jay Kratchmer talking at an EBA luncheon. And he says whenever he goes in to see a patient and he knows they've got keratoconus, he'll pick up the chart before he goes in and he'll look and he'll see that the vision has been recorded at 20/30. He looks at the topography and the patient has obvious keratoconus. And he knows that the person who took the vision spent too much time getting the patient's vision. Because keratoconic patients, they have a multifocal cornea, and often their superior cornea is pretty normal. And if you give them enough time, I mean, gosh, their whole life they've been guessing. And so you give them enough time, and they will guess the letters down to 2025 or 2030. And really, if you want to get an accurate idea of how well or how poorly the patient is seeing, get them to read the lines quickly. And you'll see that there's a big difference between how the patient performs if you get them to read it quickly versus giving them enough time to divine out that a letter is an E versus an F, or a C versus an O. And I think that that's you know, an important thing for us all to remember, is that you know, don't blow off the keratoconic patient that reads 20/25 with their glasses and they're complaining about their vision. Well, their vision is horrible. Just because they can read on a Snellen chart in a darkened room doesn't mean that they're actually functioning well. This is the same patient. This is their left eye. This is the right eye, and
had another question come through.
Yeah.
Just got a question come through just to look at that previous slide that you were just on. Would you mind repeating what you were saying about the instantaneous map for the most normal or steepest curvature?
The instantaneous map
on this,
sorry?
I believe it's this slide that they're referring to.
So read the question for me, please.
So could you please repeat what you said about the instantaneous map for the most normal or steepest curvature?
For the instantaneous tells us where the center of the cone is. It's the axial that you're looking at the curvature values, and you're looking for what that cornea is doing from a refractive point of view. So the instantaneous is to help you hone in where the pathology is. The axial of what the cornea is doing from a curvature point of view or from a refraction point of view. Okay, let me know if I didn't answer that to your satisfaction. But Okay, so this is the other eye, and there's a good chance that this patient is maybe left eye dominant, or maybe they sleep on the left side, maybe they've got floppy eyelid syndrome, and or they rub their eye. We had 3 patients that came from the Tourette syndrome clinic, and if ever you've wanted to be convinced that eye rubbing is a factor in keratoconus, this is the place to find it. As all 3 of these patients had a very interesting way of controlling their tics, and that was by taking their thumbs and pushing on their eyes. One of them selectively did it only on one eye, and that eye had severe keratoconus, whereas the other eye was fairly normal. And you know, I think most people will believe that eye rubbing is a factor in keratoconus. What I say is that if you take any cornea and any eye and you rub on it hard enough and long enough, you will develop ectasia, or you'll develop keratoconus. Having said that, there are people that are susceptible to keratoconus, and it may not take as much rubbing and as much pressure in order to induce it. So there is a combination of, you know, genetics and behavior that can lead to keratoconus. I can't imagine that there is actually people on the other side of the fence that believe that eye rubbing is not a factor, but we know in atopic patients and vernal patients, patients with, like I described to you, with tics that rub their eyes, you know, they develop keratoconus. So this is the other eye, fairly normal looking. And in fact, it was classified as normal. This is the representation on a pentacam. We'll skip over. We'll talk about this in more detail when we get to the lecture on tomography. And here is another example of keratoconus. You'll see the hot spot on the tangential. You'll also see the very steep cornea. And if you draw a straight line through the wing of or through the blade of the propeller, these 2 axes are not orthogonal. They're not in a straight line, but rather they're skewed. And we'll go on here a little bit farther. How are we doing time-wise? We're almost at an hour. Okay, so we can continue unless anybody, well, if you have to go, you can hear the recording for the rest of it, but we'll continue on. This is a patient also with keratoconus, and this cornea is so steep that is actually in the white zone, so it's greater than 70 diopters, and it's a very central cone, as evidenced on the instantaneous map, and you can see the irregularities on the Placido image here. Now, this is, I like this slide a lot, because whenever you show this crab claw appearance, which is what the axial map demonstrates, and it's evident on the tangential as well. Whenever you show these to, let's say on an OCAP exam or an oral examination, the first thing that the trainee jumps to is to call it pellucid marginal degeneration. And I think that it's not pathognomonic, for one thing. And the thing you've got to watch out for is the axis of the bow tie. Here, you can see it's at a diagonal axis. And we know that when you look at a patient with keratoconus, their axes are usually like this. The left eye is at 35 or 45, and and the right eye is at 135. Whereas in pellucid marginal degeneration, it's almost always pretty close to the 90-degree axis. So you get against. So I wouldn't jump to the conclusion that this patient has pellucid marginal degeneration. For that, you need to look at the slit lamp examination and see that the cornea is very thin on the lower 2 or 3 millimeters from the limbus, and also that the astigmatism is orthogonal. Usually these patients have 15, 16 diopters of astigmatism, and it's very, very much against the rule. So don't be fooled by that. And I hope if you remember one thing from this lecture, remember that one, that not all kissing birds are pellucid marginal degeneration. Now, this is one area that I think you really would have. I don't think you could practice refractive surgery without at least corneal topography. I think you need tomography as well. The topography isn't enough. But before we had tomography, I think that's been more commonly available for at least the past 10 years. All we had was topography and ultrasound pachymetry to help us okay patients for being safe for refractive surgery. So when we screen a patient for refractive surgery, what we're trying to do is to rule out, of course, those that are poor candidates that actually have keratoconus, or for those that have preclinical keratoconus that we think may develop keratoconus if they're not if they're not attended to, or if they have refractive surgery. And of course, we want to rule out other pathology, pellucid marginal degeneration. And what we're really trying to do is reduce the chance of inducing keratoconus. Keratoconus is a fairly common disease, but we don't want to add to the incidence of it. There's enough patients out there that need cross-linking and need contact lenses, and unfortunately some of them require corneal transplants. We don't need to make more business for ourselves. And here's an example. This is a patient who underwent LASIK a number of years before, and the only thing that makes it look slightly unusual is that it's not that much on a diagonal. It's vertical, but in many cases of ectasia, it doesn't have to be like this. It looks like keratoconus when you look at the topography, there's the old adage that if it looks like a duck and it walks like a duck, then it probably is a duck. So sometimes it's very, very difficult to distinguish from a regular keratoconus in a patient who hasn't had refractive surgery. So these are the things, the list of things that we look at. We look for irregular astigmatism. High astigmatism is one risk factor for keratoconus. Steep corneas, sometimes those. I've seen one patient that I can recall that, even though had normal thickness, went on to develop ectasia, and the only thing that I could see from the preoperative exam was that the corneas were sort of in the 46, 47 range, which should at least light up a light or make you think about the safety of refractive surgery. Then we want to look at the bow-tied pattern of astigmatism, whether it's straight up and down and across, so like with the rule or against the rule. And some people say that against the rule is more worrisome for development of keratoconus, and I'm not sure where that derives from, to be honest with you. And then we want to look for a skew, whether the one axis of the airplane propeller is greater than 15 degrees to the other axis. We want to look for inferior steepening, and then we want to look for an inferior superior difference of usually around greater than 1.5 to 2 diopters. So you'll take a point, and I believe you usually take it at the 5 millimeter around the center of the pupil, and you look at the point above and the point below, and if it's greater than about 1.5 or 2 diopters, in other words, steeper on the lower half of the cornea, then you should start to worry that perhaps that patient either has formed frust keratoconus, real keratoconus, or is at risk of developing keratoconus. And here's an example of, with the rule astigmatism, there's a slight skew to the axis and slight asymmetry. But if you look at the corresponding numbers, there's not a huge difference. There's maybe only about a half a diopter of difference in this instance. And this is more obvious, where the axis is not only on the diagonal, but there's a skew to the axis. And here's an example of showing some inferior steepening. And of course, look at the scale. In order to highlight that, I had to change the scale to half a diopter. With the 1.5 diopter scale, it doesn't show up nearly as obviously. And here's another example of inferior steepening. All right, I think I'm going to call it quits for today. I've done a lot of talking, and I'd be glad to share some time for some questions if anybody has any questions. Okay, anybody awake out there? All right. So we'll pick up from this point. We've talked about the diagnosis of refractive patients and how do we rule them out for LASIK or PRK. And next time we'll talk about how we use it in post-operative conditions as well. Thanks very much.